I'm Noreen McDonald. I'm a professor at UNC Chapel Hill, and I'm joined here by Mary Wolf. We're going to be hosting today's webinar. So we'll go ahead and get started. We'll have our video actually off for most of the time, but hopefully everybody has their screen shared. And if you do have any issues that come up, please note that there's the chat box, so please feel free to use it. Let us know if anything, if you're having any technical difficulties or if you have any questions. Okay, so I'm going to go ahead and get started today. I wanted to talk please let me know, somebody noted that they were having difficulty hearing me. Let me know if anybody else is having that issue. Okay. So I'm going to go ahead and get started here by taking a little moment to talk about how this research came about. So this webinar is hosted by STRIDE, which is the Region 4 University Transportation Center, and the University of Florida is the lead institution, and the University of North Carolina at Chapel Hill is one of the part of the 10 universities that are part of this consortium. And so our research center is focused on the Southeastern region and focused on novel strategies for reducing congestion. So a lot of great work going on through the center, and at the end, I'll give you more information about how you can connect with that work. So I wanted to put this up. There is a survey that Florida is collecting to make sure they meet needs about what people are looking for in the webinar series. So you can copy this. Also, if you go to the chat window, the URL is there as well. I will put this back up at the end of the presentation in case anyone doesn't get it now. All right, so I'm going to go ahead and get started. My name is Noreen McDonald. I'm chair of the Department of City and Regional Planning at the University of North Carolina at Chapel Hill. I also have with me Mary Wolf, and I'll let her introduce herself.
Hi everyone, I'm Mary Wolf. As Noreen said, I'm a PhD candidate here in the Department of City and Regional Planning. My research focuses on transportation and health. So some of this work we're talking about today has been a part of my dissertation and my work with Noreen over the past few years.
Great. So we are so pleased to get a chance to share this work with you. This is work that was funded by the U.S. Department of Transportation through STRIDE. So we hope that it's beneficial for us here in the Southeast as well as more broadly. So moving on to what we're going to do today, we have this presentation that you'll see, but we'll have ample time for question and answer. So we're looking forward to that. I'm going to start off by giving you some background on some of the transportation barriers to healthcare, and then I'll turn it over to Mary to describe our work in more depth. Really scoping out how large transportation barriers are to healthcare, how many Americans are experiencing this difficulty, and looking at how new mobility options such as ride-hailing, Uber and Lyft are changing the way that people can access medical care, but also creating questions about how those new options interact with the substantial amount of work that our public transit system does to get people to health care. And so again, you can see at the very end, we'll have time for question and answer. All right, so I'll go ahead and get started with a little bit of background thinking about access to health care. So transportation barriers to care, I think all of us probably, certainly in our personal lives, but for many of us in our professional lives as well, see evidence of how important simply being able to get to medical care and how that involves many different aspects of the transportation system. Many people are lucky enough to be able to have a private vehicle and use that to access care. But many others, either because of mobility difficulties or lack of auto ownership, utilize other means, including the public transit system. In public health, when they talk about transportation, they talk about transportation as a social determinant of health. And so those are factors like food, like housing, social support, our friends, all of these things that are really critical to how our health is and how it's maintained over our life course, but really are outside in many ways of the healthcare system. And so transportation has become, I think, increasingly part of the conversation because there's a recognition that they're an impediment to healthcare, especially for those who are older, have lower incomes, or are underinsured. And what we also see is that the transit system, and that's through both the fixed route, the bus system, is critical to providing access, although sometimes medical facilities aren't located near where bus lines go, which can be a problem. There's also very extensive support for a demand responsive system using funding from the Federal Transit Administration, from state departments of transportation and health and human services, along with usually local supplements. And these are programs that provide access to medical services, also special services for individuals with mobility difficulties or for seniors. And so all of these services are actively involved in getting people to medical care, but when it doesn't work, when for some reason people miss or delay care, what we see are adverse health outcomes. And that can involve, in the most serious cases, people missing preventive care and then having to use an emergency department, which means for that individual, the circumstances have probably gotten much more difficult. And from a system perspective, it's a much more costly setting in which for care to be received. And so some examples that people give in this case are individuals who require dialysis, who need to seek dialysis often about 3 times a week, and missing treatment can have very, very strong adverse health outcomes, which usually does result in going to the emergency department. And so there's been situations that we'll talk about as we come up where providing the trip to the dialysis facility has important positive outcomes, both for the healthcare system as well as the individual. So that's sort of setting up why access to transportation, access to healthcare is important, and how transportation plays a role. I think there's another point, which is why are we talking about this right now? And there's a special set of policy changes along with technology changes that mean that this is an important topic right now. So I'll start by talking on the policy side, particularly on the healthcare policy side. So with the Affordable Care Act that passed back in 2010, there was the creation of these accountable care organizations, which are value-based care, or managed care is another term that we see. And I think the important thing to realize here is this means that insurers may be receiving a payment on a per capita basis, and they're given the flexibility to provide to meet people's social determinants of health. So that includes transportation, it could include food access, can include housing, but I would say transportation seems to be one of the main ways that under managed care people address social determinants of health. So now we have a way for the healthcare system to actually expend money on transportation. And of course, we have long-term support of access to transportation through the Medicaid program, which has had a benefit on non-emergency medical transportation. We also have a very recent change in 2017 that medical providers can now provide transportation to patients without penalty. Prior to that, there was some rules in place where you didn't want to provide necessarily inducements to certain kinds of medical care. And so those rules have been softened or eliminated. And then on the technology side in 2018, and really going on for about several years prior to that, we have this extreme proliferation of new mobility options that come about through technological advance. Estimates now that nearly half of Americans have used some form of ride hailing, such as Uber and Lyft. And so of course they're using that to do many different things, including accessing healthcare. And what we'll see is how both on the transit side, but also on the healthcare side, they're adapting to this new set of options. And so here's an example. This is an image from Lyft's website. Lyft commits to cut healthcare transportation in half by 2020. Uber has launched Uber Health. So what we see is a recognition from some of these new mobility options that accessing healthcare is a very, very large market, and they are partnering with transportation providers and also on the hospital side. So now I'm going to turn it over to Mary to describe our work in more detail.
Thanks, Noreen. So I'm going to go ahead and just lead into our research questions, in particular, 2 research questions that we ask as they relate to healthcare and transportation to that care. And I'll also briefly go over the methods we use to answer those questions. The first question we asked was, how many people in the US delay medical care each year because of a lack of transportation? So you may in your own work have come across a statistic from 2005 by some great researchers who found that 3.6 million Americans delay or miss care every year because of a lack of transportation. This estimate has been really helpful in our own work in shaping our ideas about this really significant problem, but we also recognize that it was outdated at this point, and you'll see this statistic come up a lot. 3.6 million Americans have transport barriers to care. So our first objective really was to update this number using nationally representative data. The second research question we asked, can you just click on the screen, was how is ride-hailing technology changing healthcare transportation in the US? And this really speaks to the sort of change in tide that Noreen mentioned about policy changes and proliferation of shared mobility in our everyday life that might lead to some more significant change in the way that people are getting to care today. So to answer research question 1, which was again asking how many people in the US miss care every year because of this barrier, we used a nationally representative data set called the National Health Interview Survey, sometimes referred to as the NHIS. And we leveraged a specific question on this survey. The question asks, there are many reasons people delay getting medical care. Have you delayed getting care in the past year because you didn't have transportation? This question is asked of adults and children. So, and because it is a nationally representative data set, we're able to use sampling weights to come up with a nationally representative estimate of this number. For those who answer yes to this specific question, we would record that as a transport barrier to care. We looked at longitudinal trends in this specific question over the time period from 1997 to 2017. And of course, I'll share our findings from that question next, but just to let you know about the methods for the second research question, this was primarily a qualitative analysis in which we conducted a nationwide scan of all media, news, and even academic sources since 2005 using a fixed set of keywords. So things like shared mobility, transportation network company, Uber, Lyft, ride hailing, care, medical care, you get the idea. Since 2005, any instance in which these terms were used, we searched these articles and these papers to really try to catalog any instance in which ride-hailing technology was utilized to connect patients to trips for non-emergency medical purposes. So this is what we think about when we talk about these types of services being used to access care. We operationalize this idea to try to search for coverage of instances where this was taking place in the US. When we found any instance of this type of collaboration, we gathered lots of information, in fact, about 20 key variables from each article as the information was available. But for today's purposes, we'll talk specifically about the 4 that we really honed in on. And these 4 variables helped us to create the typology of innovation that we'll share with you. So we looked specifically at the stakeholder involvement, who's involved in this collaboration. We looked at the booking method. So something very basic that we want to know, right, is who is booking the trip? Is this something a patient can book on their own? Is this something a medical care provider is booking for the patient? So that's a key variable we looked for in each instance. We also, of course, wanted to know who is paying for the service in any given instance. And then, are there any measured benefits or outcomes being reported for each instance? So we'll go ahead and share our findings for these 2 questions. Again, for question 1, we asked how many people are delaying care every year because of a transport barrier. And I'll show you the longitudinal look of this variable over time. So again, this is the frequency of transport barriers to care from 1997 to 2017 for all ages. So this is including children and adults in the US. And the first thing you'll see is that there is some variation over time, but largely the proportion is hovering around 1.8% if you're sheerly looking at that proportion over time. But we do want to note that there is evidence of linear growth in this trend over time. In fact, there's a significant linear trend of an increase of 0.03 percentage points every year from 97 to 2017. You'll also notice, of course, the spike around the Great Recession. This is something that we would expect to see as people have financial hardships. We would expect to see this affect their lives in many ways, including their access to transportation. And then at the very bottom, you'll see the raw count of Americans who report this barrier every year. So you might recall that I said our best estimate before was about 3.6 million Americans. And now we're seeing that this number is actually about 5.8 million Americans in 2017 reported a transport barrier to care in the last year. For research question 2, we asked how this technology is changing the way people access care in the US. And after that nationwide scan of periodicals and academic sources, we identified 53 instances of ride-hailing collaboration. And that's sort of a collective term for these instances in which, again, ride-hailing technology was being leveraged to get people to care. So that might look different in different circumstances, but this is where our data collection came into play, because we would have now analyzed the variables that we collected in each instance and come up with what that looks like within a typology. So putting like with like. We looked at stakeholders, booking methods, who's paying for the service, as well as those benefits and outcomes, to arrive at a typology, to put together these trends and try to suss out what all of these different partnerships mean for people who maybe in their own community are looking to implement something like this. And we came up with 3 models of innovation. So 3 different types of sort of collaborative engagement between ride-hailing use and healthcare providers. So at the top of your screen, you'll see our 3 categories for our typology. So our 3 types of collaboration or innovation. The first one I'll talk about is any instance in which a healthcare provider was leveraging ride-hailing technology. If it sounds like a sort of general idea, that's because it is the largest category of innovation that we identified. So we found the most instances that actually fall into this type of collaboration. And the key here, the main takeaway for this type, is that it's all about ride-hailing services being tailored to the needs of the healthcare industry. That's the main takeaway from this category. And the key there is adding a level of HIPAA compliance to already existing ride-hailing frameworks. So again, using HIPAA compliance, making information about booking transportation amenable to the patient information and protection that is inherent to healthcare information. So making sure that information is protected at all times. So briefly, in this type, we see that often clinicians are booking the services on behalf of patients. That's not always the case, but that tends to be what we see most often happening. In instances where healthcare providers were leveraging this technology, we saw many cases where healthcare providers were actually paying for this trip. But we also, at the same time, saw instances where the transportation brokers that previously, are working with NEMT trip making and trip booking, they're also covering some of these trips in the cases of Medicaid beneficiaries. We also saw instances where a patient is actually paying for the service out of pocket. So you can see this varies greatly across what the location was and where this service was implemented. Benefits that we saw reported in these instances were, first and foremost, that clinicians are booking on behalf of the patient. So sort of removing this hassle, if you will, of a patient having to book transportation every time they have an appointment. This can get, of course, burdensome with some chronic disease management. So the fact that clinicians are able to book an appointment for the patient upon discharge was reported in many of these circumstances as a key benefit. Importantly, the integration with electronic health records seemed to be a thread throughout all of these cases, that the HIPAA compliant platform in which a healthcare provider can book a trip for patients was easily integrated with their existing software, the software they were already using. That seemed to be key as well. We also see things like reminders and tracking of patients via the app on a phone. So not only can clinicians see when the patient is or is not arriving, but patients can also see when to expect their ride to pick them up for their perhaps very important medical appointment. Through this digital integration, clinicians can also track spending. And we call this dynamic booking, this ability to book far in advance or very close to the appointment itself. That's also reported as a key benefit in many of these instances. So 2 examples that we'll just talk about briefly today of the many that we found are the example of Uber Health and the example of Ride Health. And we do want to know we have no affiliation with these organizations. This information is solely based on what we were able to find in the public domain. So for the example of Uber Health, this business line of Uber launched in March of 2018 after an 8-month trial with over 100 healthcare providers. So all the while, Lyft had various partnerships that were being reported on in the news media, but we found that Uber Health was piloting a similar service and then launched later after Lyft had kind of made what seemed to be some headway in this space. So access to the dashboard for this service in particular is free to healthcare providers, or it was free at the time of our data gathering. This space changes very rapidly though, so I would not be surprised if information on Uber Health's website is changing as we speak. But at the time, the access to the dashboard was free, and healthcare organizations who wanted to use the service were charged only for the cost of the ride, and they were being charged at the consumer app rate. For a similar but different service, we saw Ride Health. So this was not an existing ride-hailing company, but a company that launched in this space specifically for this need of healthcare transportation. And what they do is consolidate multiple ride vendors. So both ride-hailing companies like Uber and Lyft, but also existing NEMT transportation providers. So they're sort of acting as an ad hoc broker, if you will. And they report on their website a 96% on-time arrival rate for patients and a 30% cost reduction per ride. And here's a screenshot of that second service where this would be what a clinician would see. Oops. This is what a clinician would see when they were booking a ride on behalf of their patient. The idea is that they can see if the patient is running late and they can send updates to the driver if needed. Okay, let's move along then to the second type of collaboration that we identified in this scan. These are instances when an insurance company is partnering directly with a transportation network company or a TNC. So it is what it sounds like. It's insurance companies who are, like Noreen mentioned earlier, taking the idea of social determinants of health into their own hands and addressing transportation and transportation barriers as a part of the benefits offered to their members. So in these instances, again, it varies from one case to another, but we saw instances where both patients and clinicians can book rides on behalf of the patient. In this case, of course, the health plan itself, the insurance payer is the one paying for the service because it's inherent to the idea of this is a benefit they're providing to their beneficiaries. And then benefits that we saw reported for this type of partnership, of course, is the financial support being key. So the rides that are covered for patients. This is something that will no longer be an out-of-pocket expense for some members. Again, it's addressing the social determinant of health within the insurance world. Some payers reported greater patient engagement. So this idea that members might be more interested or more vested in this specific service if they know that it's part of their health plan. And then, of course, the idea that insurance companies are making the investment upfront so that they see reduced costs in health as they relate to health costs over time. So a key example of this type of partnership is when Blue Cross Blue Shield partnered with Lyft in May of 2017. And this applied to just certain Blue Cross Blue Shield company plans. And at the time of launching, that was about 106 million Americans. So certainly not a small feat. And lastly, I'd like to talk about the third model or type that we identified. And this is when a paratransit provider was partnering directly with a TNC. This, as you can imagine, was spread out all over the US and not super common. It was the smallest of the typology, but it certainly carries a lot of important information, I think, because probably some of you on this call are interested in what transit agencies can do to sort of address these barriers. So what we saw with this model is that usually the riders of the transit agency, or patients, as they are also in this case, since they're accessing medical care, they're the ones booking the ride, and they're doing that through their transit agency. So the transit agency is often paying the fare. However, the patient in some cases is paying a fare with the subsidy coming from the transit agency. And in the example I'll talk about, you'll see how that sort of played out. Benefits reported for this model are that the dynamic booking, again, this ability to book both very far in advance or sort of at the last minute, this dynamic booking decreases the need for advanced booking requirements that are sort of infamous with some of the paratransit provision in the US. We saw reported increases in reliability of service and reduced no-shows for people who would typically ride demand response service. So an example of this third type is the Massachusetts Bay Transit Authority, MBTA for short. They have a paratransit service called the Ride, and in September 2016, their paratransit service started piloting a program with both Lyft and Uber. As far as I know, the pilot has been extended several times and is still ongoing today. This partnership has allowed eligible Ride customers, so again, customers that were already eligible for the paratransit service here, it allowed them to sign up for one of two TNC services. So they could either sign up with Lyft or Uber, not both. And once they were enrolled, they could request rides through that service via a smartphone app or by using a call-in service with the Lyft partnership. Riders of the Ride received subsidized rides depending on their existing eligibility. So, and you can actually check this out. The MBTA has a great website and you can click through if you're curious about what this looked like. But riders can first assess their own eligibility for the paratransit service, and then from there, that dictates what services are available and what subsidies are available given their eligibility with the paratransit service. Something to note is that these two sort of wings of this service, so the Uber offering or the Lyft offering, do not have enhanced level of service for people with mobility limitations. So if people were riding paratransit because of a mobility limitation in the first place, they likely would not be able to utilize these ride-hailing services because it was not guaranteed that vehicles would be accessible. So we will wrap up with the findings there, but we do want to have a bit of a discussion before we open it up to questions. What we saw in this study is that ride-hailing options are very much becoming a part of the choice set for patients, but we're seeing it in selected areas. So of course, we found 53 instances in the country where this was happening. So it's clearly not becoming available for most patients. We also noticed varying levels of implementation. So by this, we mean that in cases where ride-hailing service was being leveraged for healthcare transportation, it very much varied what that service looked like. So at a very basic level, we saw things such as a promotional code for Lyft or Uber was posted in the discharge area of a community hospital. So you could pull out your phone and get $5 off your first ride. That's sort of a base level of the type of use of this service that we saw. But on a more sophisticated level, we saw, for example, in the case of Blue Cross Blue Shield, when an insurance company was actually paying for a ride to and from care. And then all the way at the top, sort of highest level of sophistication is when we actually see the digital integration of digital health records or electronic health records with the ride-hailing booking process. So this obviously takes a good deal of effort to get these things working together, also a good bit of money, I'm sure. But that's sort of the highest level of sophistication that we saw in terms of how these services were being implemented. Of course, a theme throughout this work is that we see it again with the reporting on these issues, is that the on-demand nature of these rides and the integration of the ride requests with the payment option has been critical to seeing these things not only to fruition, but essentially to see them in the long term. So in other words, the integration is one thing, but it seems to be that being able to pay for these rides quite easily is also key to payers and healthcare providers. We did want to just mention two examples you may be wondering, has this been studied? Have any of these interventions that use ride hailing, have they been studied formally, and is there work on this? And in fact, there were two that we wanted to touch on. 2 years ago, researchers at the University of Kansas did a study that looked at the potential substitution of ride-hailing services for ambulance use. So presumably this is ambulance use that is perhaps not emergent in nature. And they found that an average of 7% decrease in ambulance utilization when UberX was introduced in various cities. And they looked over a time span of 2 years. So we have that there in case you wanted to read that paper is there. And then one other more recent study from 2018, and I would not be surprised if many of you had heard about this. It was in the news a good bit. A study from Philadelphia by researchers at Penn Medicine. They actually conducted a randomized controlled trial where they offered a free Lyft ride to medical appointments for Medicaid patients. They didn't see a reduction in the rate of missed primary care appointments. And the researchers do a great job of talking about why they think that might have been the case, especially given their specific patient population. But again, it's really valuable to see these types of studies being conducted to see how effective or perhaps not effective such offerings may be. So lastly, we'll just wrap up here with a brief conclusion, and then we'll open it up to questions. We'll have plenty of time for some of your questions coming in. This research has been underway for a little while now, and if there's anything that we've learned about both from the policy context as well as just the popularity of shared mobility in our culture, it seems to be that the time is ripe to be integrating not only the way we get people to care, but the way we think about getting people to care. So thinking about, and it may not just be ride hailing, but thinking about how we can expand our offerings of transportation to really think about social determinants of health in a way that works for people and a way that produces positive health outcomes. We noted earlier the various incentives for care providers, for insurance companies, and most importantly for patients to improve access to care. One thing that we think is important, though, is that the efficacy of these types of interventions, so when we see ride hailing being leveraged in these various situations, that needs to be better understood because it's not clear what the equity implications of these offerings have been. And a large part of this has to do with the patient level of comfort with these services. So do these services work for all people? As I mentioned in the case with a partnership in Massachusetts, is that this service wasn't expanding access for people with mobility limitations. So it's just something that we'll have to think about moving forward, and affordability will certainly be central to that discussion. We do think it's important to note that traditional demand response services will be critical in both in the near term and in the long term. Traditional demand response services are carrying a lot of these trips today and will carry a lot of them tomorrow. So we want to think about perhaps how ride-hailing technology can be leveraged by transit agencies and demand response services now to make their services stronger, and not just think about substituting one service for another. And as I mentioned, it should always be top of mind to be thinking about the lived experience of the target users. What does the level of service look like for people who are using these services? And making sure that the service is working for the patient and enhancing their service, not merely making things more cost effective for people on the other end. So we'll wrap up there. We'd love to hear any questions that you have, and I see some coming in the chat box. So let me make that a little bigger on our end, and we'll go ahead and address the question, read the question for the group, and then we'll address them as we go.
So I think one of the first questions that we have is, did you look at the characteristics of those who missed or delayed care, as well as a question about what percentage of the population that missed care have insurance? So yes, that was something when we looked at those people that report missing care due to transportation barriers, we have all the demographic information for those individuals as well. So we know what percentage have insurance, we know how old they are, what gender they are, whether they have chronic conditions or not. And so the profile of that, I think, was similar, concorded with what previous findings have found, that the prevalence of barriers was higher among individuals with chronic conditions, among individuals from lower income groups, and also older individuals. And the second question that we have here is, what health performance measures would you suggest for a transportation project that connects people to healthcare appointments? So here, I think I want to bring in two dimensions, highlighting some of the points that Mary mentioned. In terms of the healthcare metrics that are often used in this space, is looking at the no-show rate or rates of missed appointments. Sometimes people try to look at emergency department admissions to look at sort of instances that may have caused high amounts of care. I think one of the things that we've come to think about a lot in this space is also recognizing the importance of quality of life indicators that patients are experiencing. So these might actually be some of the ones we more traditionally look at in transportation, such as how long people are spending traveling to care, you know, what's your average trip time, how did people schedule the ride, how far in advance were they required to schedule, as well as looking some spatial analysis, looking at how a transportation investment or a project focused on healthcare might affect some of the accessibility measures, like how many dialysis centers could an individual reach within 30 minutes, or really the question is, could they reach a dialysis center? And you could do that for hospitals, for urgent care, you could do it for many different kinds of things. So I think from the metrics standpoint, there's a wide variety that could be implemented.
We have another question about the first research question we talked about. So they ask, in the original national survey you reviewed, were there examples of what types of transportation barriers patients encountered? It's a great question. We would love a little bit more detail on that question, but unfortunately the survey asks about barriers to care moreover, and then transportation barriers is one of those within the subset of other barriers. So the survey asks about whether an appointment was cost prohibitive, whether the service was outside of the time that they could get there given their work schedule. It asks about, was the wait time too long for you to get the appointment? And then of course the question about transportation barriers. So these were all about different types of barriers to care, with transportation being one of those. So we only have the binary measure of yes or no to a question about transport barriers to care.
I think that's all the questions we have in the box so far. We'll keep monitoring it. Oh, here's another one that popped up. So this question is, what's the percentage of eligible patients among those who are eligible but can't use TNC services because of physical conditions? So I think this might be referring to Mary's point about how not all Uber and Lyft vehicles are necessarily accessible vehicles, and sometimes it can be difficult to guarantee that. I don't know, Mary, I don't know a specific number off the top of my head. I think that's a slightly difficult one to get. Do you have one?
It is a hard question, especially since this isn't something that, again, given that our data collection was based on, you know, media coverage and things that we could find in the public domain. In a news brief or a press release, these companies aren't too eager to share what percentage of their fleet of vehicles are not accessible. In fact, I would say it's even harder. It's just as hard to find any percentage that of vehicles that are accessible. So we certainly don't know what the breakdown is of people who could be eligible for this service, but can't use the service due to mobility limitations. But on a per case basis, I'm sure transit agencies have this information, because remember, they're still providing that critical service to care, but they're doing so on their existing vehicle fleets. So in the case of MBTA, they're not turning people away from that service. They're simply offering those pilot services to people who can ride those specific vehicles with the still existing services in place.
And I just point everybody to the chat box. Steve suggested a link for people that want more detail on that question. So we'll keep monitoring that chat box, but I also do want to put up, so you can be looking at, as we're answering some of these other questions, the list of the upcoming STRIDE webinars that you may be interested in. So we have a question here for cities or regions that are concerned about TNCs taking a market share from transit agencies. How could these findings still alleviate concerns that people will prefer TNC services over traditional transit? So I think there's a few things that we can take away from this study. One is that the definitions of traditional transit and TNC service are becoming increasingly blurred. Many transit systems are moving forward with their own pilots of ride-hailing-like services, or partnering with these firms. So some of those distinctions become a little bit blurry as we start to think about it. I think the other one that we've talked about a lot with folks on the medical side that we've been collaborating with is simply that the costs of utilizing ride hailing are very, very expensive. So even though some of these ACOs or insurers under the value-based care models can address transportation barriers, there is no way there's enough money in the system to do that on an individualized basis with individual ride-hailing trips. And so the continued sources of funding from FTA, 5310, various state programs, Medicaid NEMT, which covers a wide variety, all of those become absolutely critical. And I would say what we see maybe as more important is moving beyond what we have right now is sort of a Band-Aid solution where ride hailing is used in almost as a Band-Aid when other solutions can't be found, and how you have it as part of an integrated system, I think, is the challenge we're moving towards. So I think that was the last question that I saw. Please feel free, more than welcome. You have our contact information, can easily be found. Feel free to reach out individually. This research is currently under review and will hopefully be coming out in a couple of different journal venues. And we will post that through STRIDE and through other sources once it's available. So we really appreciate your attention. Thank you. Thank you so much. We'll stay on quietly for a little while, so feel free to continue to use the chat box, but we'll let everybody get back to their day now. Thank you.
Thank you.